Okay, so thank you everyone for being with me this morning. Here in Brazil is 8 o'clock in the morning, and I see that participants all over the world. So I just want to share some of my experience in orthodontic treatment of impacted teeth using skeletal anchorage and this with mini implants and mini plates. So thank you again for inviting me, Professor Bong, and let's go. So I come from Brazil. This is our huge country, and I'm from Minas Gerais. That it's we make frontiers with São Paulo and Rio de Janeiro. We are in the interior of the country. We don't have beaches. So this is where we are right now, Belo Horizonte. And this is a picture of a neighborhood that we have here, the Lagoa da Pampulha, and our big stadium of football, soccer. Instead, football is not American football. We like soccer more than American football. So let's introduce the subject. We see that as orthodontists, we have one of the biggest challenge that we have is the impacted teeth. So this is a subject that attracts me since my beginning in orthodontics. So it's a subject that I like a lot to speak. And I have my presentation today. It's very clinical. I will present a lot of clinical cases, and I just want to share with you how I manage to try to correct these very challenging malocclusions. And the skeletal anchorage, it's one thing that came into dentistry for good. It's very it's a tool that we can use to manage to solution these challenging malocclusions. So as we use the skeletal anchorage, we can diminish the side effects that the orthodontic movement can cause in other teeth. So it's just the perfect tool to manage the impacted teeth. In summary, I would like to talk about some cases that we just manage the space to de-impact the possible impaction of canines, for example. So we can open the space and clear the possibility of the tooth, the impact itself, and have a passive eruption. I will show 3 cases showing how I manage this. So the main thing is extraction of the deciduous canines in the perfect time. And then I talk about surgical technique with inserting mini implants and mini plates. I will talk about a little bit of corticotomy and impacted teeth on adults. I will talk about the impacted canines and incisor root resorption, how we can manage the resorption in these incisors caused by canines, using the maxillary expansion, rapid maxillary expansion to optimize the space for bringing the impacted teeth. And then at the end, I will talk a little bit about ankylosed teeth and skeletal anchorage. And if we have time, we can show a very nice case where I have erupted orthodontic eruption of 18 teeth in one single patient. So it will be a multiple orthodontic eruption. So let's go. This is a photo that I have put it in a lot of pictures made on the time of the surgery. So this is one topic that I want to talk about, because we as orthodontists, the majority of the orthodontists just don't like surgery a lot. But this moment where we need the surgeon to make the surgery, but the surgeon, almost the majority of them don't know a lot about bonding process on enamel. So the presence of the orthodontist in this moment for me is crucial. So whenever you have impacted teeth and you want to bring them into the mouth, you need to bond an attachment or an eyelet or a bracket in this tooth. So in this moment, it's very important that the presence of the orthodontist within the surgery, helping the surgeon. Okay. So my lecture is based on this book. This is the first edition of the Adrian Becker book. I have met him in 2004 here in Brazil. He came here to lecture, and this was an international symposium on dentofacial development and function in August in 2004. And I have the pleasure to meet Professor Adrian Becker, and we share a lot of information. I have presented this case with multiple eruptions, and he was very interested in my case. So we have made friendship, and I met him a lot in all the AAO meetings that I participate. I always met him. So this is a picture in 2008 where we are sharing some other interesting cases on impacted teeth. And this is his book, and it's the second edition of his book. It's a very interesting book. In this compiling of, maybe he's the one that published more about this subject of impacted teeth. And then I met him again, this time with Stella Shaushu, that is her substitute now in Israel. And this is Dr. Lee Graber that was with us in this moment in the AAO. This was in San Diego. Okay, so this is a nice article that a group of Italy talked about the preventive treatment of ectopically erupting maxillary permanent canines by extraction of the deciduous canines and first molars at the same time. So we have already known that this strategy of extracting the primary canines to change the path of eruption of the canines, it's a very interesting tool to use. But this group say that not only the canines, but also the first molars, the deciduous molars, at the same moment can be a favorable to get these canines de-impacted. Okay, so this is a case. It's a little girl. I'm just passing her photos. She was with 6 years at this time, no problem at all. His panoramic looks good. And then I was accompanying her. She was growing, and now she's here having the permanent teeth erupt, and now we can see that the canine is lacking a little bit of space, but nothing wrong at this time. So as she's growing, both canines are coming to mesial, and they are above the roots of the lateral incisors. So at this time, I thought maybe this is the time to extract the canines, the deciduous canines and the first molars, to try to have some space so these canines can alter their path of eruption and come into the right position. So this is a TC that we have made, and we are almost having a transposition on the left side. So we made a study on this, and then we make the decision to extract the canines and the first deciduous molars at this time to maybe to change the path of eruption of the canine. So we have made the extractions, and then we are just waiting a little bit to see if the canine, both of canines, will come for the distal tip to come out of the roots of the lateral incisors. So this was what's happening on the left side, but on the right side we have also an image that suggests a cyst, eruption cyst, between the root of the lateral and the canine. And we know that maybe we can have a root resorption on the lateral at this time. So I have made a decision to change the position of the roots of the incisors, the lateral incisors, going the roots towards mesial, to maybe change the path of eruption of these canines. So that's what we did. We made another tomography, a CT scan, and on the right side it's really bad. The canine is almost touching the root of the lateral incisor on the right side. So at this time I have to make a move. So I talked to the mother, and we will just try to put these roots, the lateral roots, towards mesial, maybe to change the path of eruption of the canine. So that's what we did. Can you see that I have bonded some traditional brackets? We call this therapeutic here from 2 against 4. So we have bonded the second deciduous molars with tubes, and we bonded the brackets on the lateral incisors, counter angulated to give these roots towards mesial. And then we enter with the coil spring, but you can see that the bracket it's bonded with an angulation that will give the roots to the proper position. So that's what we did. And then I have de-impacted the right canine, and now the canine is coming okay. So I removed the brackets, and then we altered the path of eruption of both of the canines. And then the canines erupted well, without the need of any other therapeutic, orthodontic therapeutics. So I just removed the brackets and let the nature goes by itself, and the canines erupted very, very nicely. So this is another case, similar case. This is my niece. She had a lack of space in both arches, and we always do a maxillary expansion for these cases. And then it was happening on the right side. The canine, it's very near the lateral incisor root. So we made this CT scan, and this is the time that we have decided to extract the canines, the deciduous canines at this time, to maybe alter the position of the canines. So at this time, she had already made the extraction. The first premolars have erupted, and the canine still very close to the root of the incisor, the lateral incisor. And now we just waited a little bit, and then we can see that the canine by itself, it's going towards distal, the right canine. I will just put the 2 X-rays like this, so you can see that the canine just moved towards distal. And this was, nothing was done, and unless the extraction of the deciduous canines and the first molars, deciduous molars. So it was very interesting. And then she had braces. We opened the spaces, and the canines is just coming passively, and they erupted very well. So you can see also the inclination of the canine is towards the crown, it's towards distal. just for extracting the primary canines at the right time. And then I have just bonded some brackets. I used a lot these self-passive ligation brackets, Damon system. This is MX Damon. I don't have any particular interest in any company, so I have to disclose that I don't participate on any company. Okay, so I was just bringing the canine back with the passive self-ligation brackets, and at the end I have used 2 mini implants just to reduce the bite protrusion, using a little bit of interproximal stripping to get more space and bringing these teeth in a proper position. And then at the end we have some finishing bands, and this is the final result. It's a very simple mechanics. We use the mini implants and omega loops at mesio, the first molar. So we apply the force on this wire, and it slides through the slot of the bracket and just distalize the molars. So this is the end of her treatment, and she got very well. Okay. Well, this is a very interesting case also. A girl, this was back in 2007. She had a crossbite at this time, and she uses maxillary expansion to correct the crossbite. And then she appeared to me at this time. The canines were very close contact with the lateral incisors, and she is growing. And now she's becoming my patient. So the lateral incisor is just touching the first premolar. So she had no space at all for the canines to come in. And they for sure will be impacted if we didn't do anything. She had already permanent dentition on the lower arch, and the upper arch just lack of one decidual molars to fall. And at this time we can see on the left side that the canine it's angulated, and the possibility of impaction is very likely to occur. So at this time we begin the treatment, and we are using some coil springs to bring this incisor a little bit forward. And I was very afraid to touch in these lateral incisors because of their proximity on the canines. So if we just bond the bracket in a malposition, we can just put the root of the lateral into the crown of the canine. It's very dangerous. So I open the spaces like this, and then I have bonded the second the lateral incisors with a very contra-angulated position of the brackets. So my intention is to bring the roots of the laterals towards mesial. So with this technique, and also the premolars, I'm going the roots of the premolars towards distal, and moving the roots of the lateral incisors towards mesial. So with this, I was just trying to open the space for the canine and try to de-impact the canine on the left side. So on the right side, on the right side, I'm sorry. So this is what we are doing, and we opening the spaces, and on the left side the canine is coming good, but on the right side still impacted. And then we just open more spaces and just try to understand if these canines will erupt passively. So at this time we have to be very patient for the wait for the canine to erupt, and maybe this will take longer, but we have to be patient. And then I have made another CT scan to see where the canine was, and then on the right side he was by the palatal side, on the left side also. And then we just wait a little bit more and try to understand that the canine is coming through passively. So you can see on the image, on the upper image, on the X-ray, that the canine was almost touching the root of the premolar. And then we are opening the space and going with the root of the lateral very near the root of the central incisors. And in the literature that we can see that maybe both teeth can share the same periodontal ligament, but this was no problem because we had no problem there. So the canine is just erupting passively. We are just waiting and doing the X-rays to accompany to understand that the teeth, this canine, it's coming passively. So we just wait a little bit more, and then the canine was erupting. I saw that the second molar was impacted also on the right side and the lower part. And then we just wait a little bit more. The canine was erupting, and then I have impacted also the second molar. At this time, when the canine erupts, we can change the position of the brackets towards the right position. So now I can change the position of the incisor lateral and the premolars to bring them their roots to the right position. And this is on the left side. It was the first bonding process where I need to put the root on the mesial, and then I just changed the bracket and I use the same bracket to position the root on of the lateral incisor on the right side. So sorry, and now it's coming very nicely. The second molar was also de-impacted, and the canine is erupting very nicely, and we are now getting to the end of the treatment. Patient was a little bit concerned about the time because it took a little bit longer than we expect, but we had success. So both of the canines was erupted passively without the need of any surgery at all. And this is a very interesting procedure, right? The patient was very happy. We had the possibility to extract the first premolars, but I think she had a nice profile right now, and I think it was a very good decision not to extract the premolars. Okay, this is the end, the final result, upper and lower, and the final X-ray with not any root resorption at all with all the treatment. We have impacted also the second molar. Very interesting, very nice case. And the profile for the patient, in my point of view, it was very good. This is what the quantity of the space that we have created, and appears very, very crazy, but it worked very good for this patient. Okay, the change on the profile, and I think I have maintained and maybe have improved her profile. This is another case very similar with this one. This will be the last case that I'm showing how we can manage the space and the impact, the possibility of impacted canine. So she was at this point, at this time, she had about 8 years old. And on the left side, we have inclination of the canine and a superimposition with the roots of the incisor, the lateral incisor. So at this point, I thought that it will be interesting to extract the primary canines and the first molars, primary molars at this time, to try to impact the canine. So this is what we did. We made a CT scan, and we can see that the left canine, it's almost superimposing with the roots of the lateral and the central incisors. So we can have also a possibility of transposition of the canine between the lateral and the central. So it's time to act. And you can see that the crown of the canine is touching the root of the incisor lateral. You can see also the number 12, the other incisor lateral has a crown deformity and the laceration between the crown and the root on the other side. So we try to manage this also at the end, doing maybe a static on these teeth. So she was growing, and we have made the expansion and the extractions, but it didn't work out on the right side. Yes, but on the left side we still have the problem. So this is the moment that we have to do the same thing I have done to the other patient. So now I have bonded the brackets on the lateral incisor, very contra-angulated, to change the position of the roots towards mesial, to maybe try to de-impact these canines. So that's what we did. We are using the same type of brackets, passive brackets, self-ligating brackets. And I just using here a plastic tube to make minor forces and try to move the root of the incisor lateral and impact the canine. So that's what we did. And we have also had success on this case. So we just removed the root of the lateral of the crown of the canine. So now the canine is coming passively to erupt normally. So we have just changed the obstacle that it was the root of the incisor lateral. You can see on this image how much is contra-angulated the bracket of the lateral to give the space for the canine. So now he's erupting passively, and then we just ended the case very nicely. And at the end, we have this result. And then at the right time, of course, we have changed the position of the brackets, so we can now put the root of the lateral on this right position on both sides. And the patient is very happy, nice profile and nice final result. At the end, her profile, and we have here just a sequential of what we did. So at the first, we have this situation, and then we remove the canines and the first molars, and then we just use the brackets to change the position of the laterals, and then the canine come very nicely. So this is just showing her profile. So these cases I have just made the diagnostic on the right time. So I had the possibility to try to just don't do any surgery at all, and just open the space so the canine that it was impacted now can erupt passively. But there are some times that we don't have this chance, and the canines and the other teeth can be impacted. So as an implantodontist also, I have studied mini implants a lot. As soon as they appear on the literature, I try to understand how these two can work. So I just want to show you very briefly how to put the mini implants and the mini plates. So maybe also the orthodontist can do these techniques, because it's not so invasive, but it's not everybody who will do this. But anyway, I will try to show you how I do it in my office. This was the first article in mini implants, Haizuo Kanomi, back in 1997. And this is a group of South Korea that study a lot mini implants. Professor Hee Moon Kyung, that I have the chance to know him. He was able to come into our city once, and then this is me with him in the AAO meeting. He's a very generous guy, and I have studied and learned a lot from him also. So, and this is an article from Dr. Park, Hyosang Park, one of the first people that have mentioned how can we manage the biomechanics using mini implants back in '99. And this is a very interesting article from the other group of Kyung-hee University in South Korea, Professor Kyo-hin Chung and his doctors. So I use this type of mini implants. It's a company called Neodent here in Brazil. I don't have any disclaimer with this company. I just learned to use their mini implants. So we do a very little anesthetic, very little anesthetic, just on the point where we are going to insert. I use instrument just to direct me between the roots. So I made a punch with a lens, just make a hole on a little tiny hole on the cortical plate. So it goes just like this. The patient has the lens inserted on the bone, into the bone. So I just remove that lens and put the mini implant, and it's very easy technique. Of course, we have to study carefully the position of the roots, but it's really a procedure that don't take more than 10 minutes, 5 to 10 minutes to accomplish in our patients. So this is just a little movie I can make, and this movie I'm doing at the same time that I'm inserting the mini implant. So whenever you make the punch on the incisor root, it's very easy procedure, as you can see. And the fact that we had just a little anesthetic, just little anesthetic, we just don't want to anesthetize the teeth, just the gum. So if the screw is touching the root, the patient will feel some pain, and the patient will let you know. So that this technique is very safe when you use it correctly. So the anesthetic must be just a little bit and just on the gingiva. So if the screw can touch the root, the patient will feel pain. And this is very easy. We like to make some inclination on this, on the position of the mini implant. And this is another movie that is just showing here that I take out the punch that I made on the cortical plate, and then just insert the mini implant with some 45 to 50 degree insertion going out of the roots. So this we can also be very close to the EZC type of insertion. So it's almost vertical, trying to get out of the roots. So it's a very simple technique, and we must have like 10 newtons of force to have the primary stability on the mini implants, right? And then I use this to make some biomechanics. I can use the mini implants to distalize the molars as this. So it's just one wire, stainless steel wire that I use omega loop in the mesio on the first molars and just use this chain elastic to distalize the molar. It's just a very easy mechanics. And mini plates was first published with Professor Sugawara and his group from Japan, and they inserted mini plates to correct open bites. And this was a very interesting procedure to intrude the molars. And this is the group of Kyung Hee, Professor Kyung Chung, and his group that I have the pleasure to meet them in October 2018. And I've been in Seoul, and it was very, very nice to know the country and all this fantastic type of mechanics that they invented. So the biocreative orthodontic strategy I use in some cases in my office. So we have to learn that we have almost in all cases, we have to have the tripod diagnostic tool to see if the patient has something wrong, right? And this is just a comparison of the normal mini plates with the Korean mini plates. These mini plates are very small and very easy to insert. So this is a comparison between the normal mini plates, orthodontic mini plates that are using on the market, and the Korean mini plate developed by the Biocreative Strategy group. And this is very interesting because this mini plate is very narrow, is very small, and it's very easy to insert. And then it is made of titanium, so we can change the position of this tube. It calls the C-tube mini plate. So we can change the position of the tube towards the direction that we want to use. And they are very practical and very interesting to use, okay? We use almost a 4mm screw to insert these mini plates. So it's a monocortical screw and will not touch the roots. So we use this technique. And this is the various positions that we can apply to use this type of mini plates. It's very practical and it's very easy to insert. So this is just the technique from the articles for the group of Kyung Hee University, Professor Kyung Chung. And then it's very easy to insert. This is a movie that I made on the Kyung Hee University. It's Professor Sunny inserting a mini plate on this patient. It's very rapid video. You can see it's just 2 to 3 minutes. You made just one incision, vertical incision, okay? And then you just take out the periosteum where you're going to put the mini plate. It's very easy to do this. I don't know if everybody is familiar with surgery, but I just tried to show you how easy it is to insert this type of mini plates. It's a surgery, yes, but it's a minor surgery. So you put the first mini screw of the fixing the mini plate on the middle, and then you can do the other 2 screws to position these mini plates. They are very easy to manage, and it's very rapid procedure. So you can see this is the first screw that was placed, and then you can position the mini plate on the right position, and then it's just putting the other 2 screws and fixed. This mini plate was fixed with 3 screws, so it's very stable. And as these mini plates are very tiny, very little, they are very easy to insert. So maybe the orthodontist can also don't need to indicate to a maxillofacial surgeon to do this. This is my thought, and also the thought of the group of Kyung-hee University. They said that this is a procedure that can be made by orthodontists and don't need to have oral maxillofacial surgeon to do this placement. But it's not anybody who wants to make surgery. So if you just don't want to do it, you can indicate for a surgeon to place your mini plates and just tell the professor the position that you want. So this was a congress that we participate in Seoul. This was the entire group, Professor Kyo-Hin Chung in the middle, our professor from Belo Horizonte here, Professor Eto, and Professor Kim of St. Louis University, and other colleagues there. It was very nice moment. I have the chance to meet a lot of, and made a lot of good friends and understand and know more the great orthodontists that we have in South Korea. And this is in the Kyung-hee University, where I've presented Professor Sunny with a shirt from my team here, my football team here in Brazil, Atlético Mineiro, and he was using a shirt on the clinic, and it was very nice to know these people there. So let's talk about corticotomy a little bit. There are some cases where we have a lot of difficulty in bringing the canine towards the position. So we know that the corticotomy induces bone turnover, so, and induces diminished, so it's like the bone density goes low and causes osteopenia. And in this way, the tooth will move more faster. It will move faster. So this is a technique that was first published back in 1893, and then we have a lot of articles. Heinrich Kohl from 1959, and then Jenison in 1978, just show a technique where he uses the corticotomy to facilitate the orthodontic movement. And this strategy can be used to erupt impacted teeth also. So expanding the limits, we can have a line between the orthodontic surgery and conventional orthodontics with accelerated osteogenic orthodontic. This red line would be just the corticotomy process. But if we can do the corticotomy and skeletal anchorage at the same time, we can also expand our limits for tooth movement. Okay, so we have getting more and more possibilities to orthodontic tooth movement using this technique. So it's an interesting article of T.J. Fisher, where he compared the same patient with two canines impacted. He uses a corticotomy on one side and the other side not, to see if the corticotomy really accelerates the eruption of impacted canine. And the conclusion that he has is that corticotomy-assisted surgical technique can help and reduce orthodontic treatment time for palatally impacted canines. So it's a technique we can use, associating mini implants and corticotomy to bring the canines to the proper position. Okay. This is a very interesting point-counterpoint type of study that Professor Kokic, that it was the editor of the AJO at this time, 2013, and he have published an article with Dave Matthews, and counterpointing the article of Adrian Becker and Stella Schauschu. The article of Stella Schauschu and Becker said that they believe that creating space orthodontically before minimal surgical exposure and bonding a small attachment and eyelet, full flap closure and immediate traction is a safe and predictable option for treating palatally impacted maxillary canines in adolescents and adults. And this is I have always in my cases I have used this closed technique, flap technique, because I think it's a chance to have a good attached gingiva at the end of the eruption of the canines. I whenever it's possible, I try to close the flap. And the group of Kokic and Dave Matthews, they believe that the pre-orthodontic uncovering and autonomous eruption technique, it's a safe and predictable option for treating palatally impacted maxillary canines, also in adolescents and adults. But in some points, you cannot recover at all. But whenever it's possible, I try to use the closed technique that is advocated by the group of Professor Becker back in Israel. And this is an article of Vincent Kokic, Surgical Orthodontic Management of Maxillary Impacted Canines. And I have the chance to have a photo with him in one of the AAO meetings. We are sorry that we lost him very, very soon. It was very brave orthodontist. So about surgical exposure, we have always the flap closing technique, but in some cases where the canine is too low in the position, we can use this technique of Professor Vanasdal, where he just reposition, they have an apical repositioning flap. And here I'm using the mini implant and just the recovering and the reposition of the flap to bring the canine to the proper position. And then we have at the end just a nice gummy result on the canine. So it's a nice strategy also. And then we have here the surgical flap closure, even in palatally impacted canines. So I always use the technique of closing the suture, the flap. And I'm just do like this. I recover, I use the mini implant, I apply the force at the same day of the surgery, and then I closed the flap completely. And in all these cases, we have been very lucky to have a good gingival, attached gingiva at the end. So this is the technique that we use. Another thing that is very common is the canine to resorb the roots of the incisor. So there are some situations that this happens, and I will show you here two interesting cases. The first one, we didn't have the skeletal anchorage at that time, so I have to use a lot of difficult mechanics. And the other case is a very similar case where we use the skeletal anchorage. So this is other article from the Adrian Becker and Stella Schauschu, and they showed long-term stability, maybe in some laterals with almost the entire root resorbed. So seeing these types of article, when I found this girl in my office, she was 18 years old at this time. And this, it was the first panoramic that she had at 12, 13 years. And she was treating with another orthodontist at that time. And the root was, the lateral incisor was resorbed almost all the root. So this is what happened. And we tried to de-impact the canine. At that time, we didn't have the skeletal, the mini implants. And then we used this maxillary expansion Hyrax to have the anchor unit to bring the canine back and then position the canine to the vestibular. to the buccal side. In the second surgery, we bonded again and a small attachment, and then we just tried to erupt. And this was a lot of side effects that we have in the mechanics, and it was very difficult mechanics to use. And then we just try to erupt this canine and maintain the lateral incisor in this position. And this was the mechanics that I have used. And it finished very nicely. At the end, we use interproximal stripping to remove the black space between the incisors. And this was the final result. We just maintain the occlusion without touching that incisor, that lateral incisor. So it will not apply any type of force in this lateral. So that's what we done, and this is the end result. A nice gingiva on the canine, and this lateral has almost no root, just the 1/3 of the root remaining. And this is almost 10 years ago, and this patient continues to go to my office, and this incisor continues there very nicely with no problem at all. So it's just interesting to see that even teeth with this majority of resorption can be stable for long term in the mouth of this patient. So this is the beginning and this is the end of the treatment, and she's doing well until now. Okay. Another case appear, very similar case. This patient was studying dentistry at that time, and she appeared with this impacted canine that she doesn't even know that she had this canine impacted. And she was presented with a deciduous canine at this time. She had 19 years old at this time. So now we can use more and more predictable results using skeletal anchorage. And we see that we have a big resorption on the lateral incisor, the left lateral incisor. But anyway, as I seen in the other case, I just try to make this. I made a rapid maxillary expansion. At that time, we didn't use any type of screw to do this, any type of implants to do the expansions back in 2008. And then we bonded some brackets, opened the space. At this time, I use a mini implant on the palatal side and just recover the canine, bonded a small attachment, and use the mini implant at the same time of the surgery to bring this canine back. The first time we just try to bring them back, and then we can see by the x-rays that the canine moves very nicely and get out of the root of the incisor lateral. And this is the time that we need to do the second surgery to bond this eyelet or this button, a small bracket, a small button on the buccal side of the tooth, so we can now bring this tooth towards buccal. And these two different movements, we use a mini implant to distalize first, and then I remove the mini implant on the palate, put the mini implant on the buccal side, and then we do some minor corticotomy to facilitate the movement of this canine towards the cortical plate. And this is how we do it. We just use here simple mechanics with 2 wires, bringing the canine to his proper position. It comes very nicely. First, we distalized the canine, and then we bonded in another surgery the bracket to the buccal side of the canine, and now the canine is coming to the buccal position. And this is the end of the treatment. And the incisor, the lateral incisor, even having a very large portion of this root resorbed, feels long-term on the patient's mouth. So that was interesting to see, because maybe we can make a wrong choice extracting this resorbed incisor instead of maintaining it. So I think this was very interesting diagnostic and maintaining the lateral until now. So this is almost 11 years ago, and this patient still has this lateral incisor on his mouth, and she's very happy with the end of the result. You can see here the periapical showing the resorption on the lateral, but still this teeth, it's very nice and it's working okay. Another adult patient, this one is a little bit more difficult, has a very deep bite, and it's almost 35 years old, and still have primary canine on his mouth and impacted canine. At this time has odontoma presented that caused this impaction, and we make this diagnostic using the CT scan. We can see that we have like a supranumerary tooth, that it was in fact an odontoma and impacted canine. So what we did, we opened the space and we do a surgery using mini implants and corticotomy and this coil spring to bring the canine to the proper position. And then you use simple mechanics using self-ligating brackets to bring these canines into the position. And now we are just finishing the case, and this was X-rays showing how we can manage the impacted canine even in adult patients. You can see here that we have a little bit of resorption on the lateral and even on the centrals because of maybe a little bit of orthodontic force. But anyway, it's just a scar that we can say that's just a scar from orthodontic treatment, and these teeth will have a very long-term stability with no problem at all. Okay, now this another patient. As I said to you, we have my presentation is very clinical. This patient has not a good profile for extraction, and we see that she has a malocclusion, lack of space in both arches. But in this right side, we have no space for the canine. So we just try to open the space and use the rapid maxillary expansion and the space generated by this expansion towards our accomplishment, that it was the space for this canine. So in this case, I have made the decision for non-extraction. And then this was the X-rays, the profile X-ray, and then a CT scan showing that the canine is touching the incisor, the lateral root, and it was between the lateral and central incisor. So if we do nothing, it will have like a transposition or maybe a resorption on these incisors. So we just try to open a big space to bring these teeth, this canine to this proper position. So what we did, this was the first panoramic X-ray, and then we opened the space using rapid maxillary expansion and using the space of the diastema to accomplish more space for this side of the canine. So just the simple mechanics, we just do a rapid maxillary expansion. And now I just bonded some brackets and used a wire, not allowing this right central incisor to come mesially. So I will use all of this space between the central incisors just to the right side, okay? So that's what we use. I just put some wire here, and I'm not letting this incisor to come to mesial. So I use all of this space to just to the right side. And then we do the surgery when we open the space without touching any bracket on the lateral incisor, because this teeth was on the buccal inclination. And if we put a bracket in this situation, we will just go the root towards the crown of the canine. So first I have to remove the canine from the root of the incisor, the lateral incisor, and then I can bond a bracket and mesialize these tooth. So I'm using a corticotomy, I'm using a skeletal anchorage, and at the same time of the surgery, we close the flap. Always we close the flap, and then we are doing a force to distalize the canine. And this is what we've done. We can see that the mechanics works very nicely. You can see that the canine is moving very fast. This is the surgery that was made in October 2012. And then just in April, 2-3 months, the canine was almost out of the root of the lateral. And then we just bond a bracket on the incisor lateral. And then we are bringing now the canine into his proper position. It was erupted. And at the end, I have used the mini implant to finish the case, okay? This is the end result. This is her profile. You see that I didn't have extracted, but she still with a flat profile. But I think it was a good decision on this case. This is the final results. Okay. Now a very challenging another case. It's an adult patient. She has a crossbite on this right side, a class 2 malocclusion with lack of space completely for this canine. So at this point, we can understand and maybe think that we maybe can extract this canine on that side and it's just doing okay. But I just wanted to bring this canine back without extracting any tooth. So I'm doing, this is the occlusal views, the panoramic x-rays, the periapical x-rays, and the occlusal x-rays. And then we made a CT scan to see what is the situation of the 3D position of the canine, right? And then we think that maybe we can open the space for this canine, right? And this is the CT scan. And what we put a rapid maxillary expansion device, a Hyrax device, and send this patient to an oromaxillofacial surgeon to make rapid maxillary expansion assisted surgically. So we can really have this patient at that time, it was 36 years old. So maybe we cannot open the suture. So we tried to make a surgical expansion. And that's what we did. This is the bonding Hyrax, and this is at the end of the surgery process. So I have made the same technique just to optimize the space of we created in the diastema between the incisors, just to use this space only for the right side. So we bond the brackets at this time, and we are not allowing the right central incisor to come mesially. So we can use all of this space for that canine that we want to bring back, okay? So that's what we did. We opened the space a lot for the canine, and then we made the surgery. This is a pontic that was in the arch for the patient static. And then we do a flap on the palatal side, bond the small bracket, and use the mini implant to bring this canine towards back, towards distal, to see how we can manage this. So at this time we had still a class 2 on the right side and a class 1 on the left side. So We are accompanying the movement of the canine. We made a occlusal X-ray to see the position of the canine. And at this time, we have to make the second surgery. Now we are going to bond the same small bracket button on the buccal face of the crown of the canine to bring now to the buccal side. So that's what we did. I removed the bracket that was bonded on the palatal aspect of the crown, and now we bonded on the buccal side. And then we just used the same mini implant that it was on the palate. I removed the mini implant on the palate, and I put the same mini implant on the buccal side. And now we are using the mini implant to bring the canine towards buccal and to distalize the molars, to have this correction of this class 2 on the right side. So I was using the same mini implant to distalize the molars and to bring the canine to the proper position. You can see the midline deviation at this time, and use the class 2 elastic on the other side to maintain the class 1 that we already have. And then the canine was appearing on the palatal side, and then we just bring the canine to the buccal side, bonded bracket at this time. You can see that now we have a class 1 on the right side also, and we are just getting the canine into this proper position, and then we are closing the space. You can see now when we distalize the molars and the premolar is almost touching the mini implant. At this time, we can just change the position of the mini implant a little bit distal to finish her treatment. And this is the end result. This case was presented for the Brazilian Board of Orthodontics, and I have tried to make, even with standard brackets, standard edgewise brackets, we can accomplish a very nice result. The patient is very happy, is very cooperative patient. This treatment took almost 4 years, 4 to 5 years of treatment, but the patient is very nice and she wanted a good result. So this is the final result for this case. And it was very nicely, and the patient was very happy with the result, maintaining her profile, and she was very happy with the result. And also I was very happy too, because whenever we had a good patient in orthodontics, this is very important to accomplish some results like this. And this is a comparison between the occlusal upper jaw and the smile at the end of the treatment. Okay, we are beginning to have a little bit more experience on these cases. And this boy was very nice boy that appeared to treat with me. And he has a class 1, a little bit of lack of space in the lower arch, and the 2 impacted canines at this time. So at this time, I thought that maybe we can extract first the canine deciduals to try to see if these canines will come to the proper position. But we can also see that the roots of the first premolars are very towards mesial. So I have to open the space for these tooth to erupt. So that's what we try to do. We made a CT scan at this time and see that both of the canines, it was very likely that they will be impacted. So I just tried to open space using maxillary rapid expansion, and then we tried to open the space for these 2 canines, bringing the roots of the premolars towards distal and bringing the roots of the laterals towards mesial, and see if with this approach, maybe these 2 canines came into position. But this not happen, and they are very horizontally in the maxilla, both of them. So we need to make surgery and bring these canines towards position. This was the second CT scans that we made. So I have opened the space for the canines on both sides. I have used the technique to bring the roots of the laterals towards mesial, bring the roots of the premolars towards distal, but it didn't work out at this time. So we just need to make surgery because this tooth will not erupt passively. So that's what we did. We put 2 mini implants between the roots of the first molar and the second premolar. We have made some minor corticotomy on the cortical plate distal to the canines. I just used a button, a small button, to bond on the canine crown, and use the mini implants to distalize them at the same time of the surgery. You can see how the brackets of the lateral incisors are bonded with the wrong inclination to change the position of the lateral roots. So we just distalize these canines. Both of them, they work very nicely with the mini implant. And then I just try to put these teeth, both of them, towards occlusal, and that was the technique. When we use self-ligating brackets, this is like 0.14 night tie wires that we can just do a minor activation on the wire. So it works like this. You just use not too much force to erupt, and it will have a component of intrusion of these incisors a little bit, but it was working very nicely. And then I can just bring those both of canines into their position, and then I can use the same mini implants that I put at this time now to have a proper position on the canines. So that's what happened. And then at this point, I can change the position of the lateral incisors to bring them roots towards distal now. And then this is the final result. I'm using here the mini implant on the right side to close this final space. And then that's what the final result we have. Very challenging, very difficult position of the canines, but we had a very nice result on the gingiva, on the buccal side, and the patient is very happy with the result also. It's a very nice patient, Leonardo. Well, I will talk just a little bit about the possibility of the anchor unit to bring maybe some ankylosed teeth towards the position. This is very challenging also. This patient has ankylosed first molar, and I used this mini plate. It was not a Korean mini plate at this time, and just to try to bring the molar upper. And she always had, she had also canine ankylosed on the other side, and it did not work out. But the molar we try to erupt work very, very nicely. We just made like a luxation, as we will try to remove the teeth, and used the mini plate. I bonded a tube on this eyelet on the mini plate, and just erupt the molar. And this is a last case here. I'll try to show a patient with ankylosed first molar. He has a very nice occlusion on the right side, but big problem on the right side. Yeah, right side has a big problem because it was ankylosed first molar. And now I just try to make a good diagnostic. So we see that he has a premolar, supranumerary premolar between the canine and the first premolar on the palatal side, and also supranumerary on the position of the third molar. So in these situations, we need to have skeletal anchorage to apply force on this ankylosed tooth to try to erupt him. So that's what we did. This is the CT scan that we had, and showing that maybe it has really ankylosed situation between the roots of the molars and the bone. So what we did the surgery. We insert a mini plate on the lower jaw, and we did extract the supranumerary tooth and made a surgical luxation on these ankylosed molars. So I just made a surgical luxation and have a big mobility on the tooth as we wanted to extract them, but I didn't extract. I just bonded this tube to try to erupt like this. So it's using the elastic. The patient can use the mini plate, and we made just a hook on the molar to try to erupt. So whenever the patient opened his mouth, he's using the force to erupt the ankylosed molar. This is a very recent case, so I cannot show you the entire result, but he's using, it's just 1 month, and I can see that the molar, it's coming back. So I think that we maybe can have a very nice result on this case also. Just a moment to finalize my presentation. I will present multiple eruption on this last patient. So I just will share another screen. Okay. So this case was very challenging case. Professor, I still have time to finish the presentation. Can we use 10 more, 15 more minutes? Is that okay?
Sure. That is okay. That's okay.
Okay.
A really great lecture. Thank you.
Oh, thank you.
Go
Thank you
ahead.
very much. Okay, so this is very nice case also. I have treated this patient almost 20 years ago, and this shows a combination of orthodontic and surgical treatment with the aim of actively erupting and aligning the impacted permanent teeth on a 11-year-old boy with a generalized eruption failure. The dentition presented some deciduous impacted teeth and almost all permanent teeth unerupted. The reasons for these phenomena are unclear. Not only there is a resorption of primary teeth and bone deficient, but also heavy fibrous gingiva that impede normal eruption. So the objectives of the treatment was the elimination of mechanical disturbances, provision of a functioning mastigatory mechanism, and improvement of a patient's appearance. So this is the boy at this time. He has this occlusion. He has almost 11 years old, and just 2 permanent incisor has erupted normally. The other teeth was also almost all impacted. This is the upper and the lower jaw. The presence just of the decidual teeth on the upper jaw, and in the lower jaw, just the 2 permanent incisors that had erupted normally. And this was the situation. So we had primary, second molars impacted. We have almost all the permanent teeth impacted, and the first molars too. So that was very challenging case. This was the profile X-ray, the occlusal X-ray, upper and lower. At this time, we didn't have cone beam CT, So I just used the X-rays to make the diagnostic. And then I just begin the treatment by a rapid palatal expansion with an acrylic encapsulated appliance with artificial anterior teeth, just to motivate the patient. So I just did this this device. So we open the space on the upper jaw, and then we just try to open the space for the second, the lateral incisors, the lower lateral incisors, just to try to see if the possibility of eruption technique with this boy will work. So I just opened the spaces for the lateral, do like a minor surgery, bonded the brackets, and then I have erupted these two incisors. And this opened for me the range possibility of bringing the other teeth as well. And so what we did, I did a modified hyrax with anterior legs of the appliance extended on the buccal side as an anchor unit to erupt the permanent incisor. And surgically, we exposed and tied with steel ligature wires, trespassing the incisor surfaces of the exposed crown, and erupted with vertical elastics to the anterior legs of the appliance. It was like this. It's just a rapid maxillary device that instead of doing these arms back, we put them forward, put some acrylic on it, and made the surgery trying to bring the 4 incisor to the proper position. At that time, I preferred to do this trespassing technique into the enamel, but in these days, I would not do this. I just bond a small attachment. But I have made the surgery alone by myself at that time, and this was the situation that I have just tried to facilitate the technique. So that was what I did. I begin to erupt these 4 incisors, and when they are coming into position, we just finally we align the four permanent incisor, upper incisor. This was very interesting at that time. Can you see these photos here? It was made by slides, and now this was the first digital camera that I bought it back in 2001. So you can see the difference of the images is because this was a slide and this was a digital photography. Okay, so now we need to bring all the teeth back. You can see that the posterior teeth have erupted a lot. I didn't use any type of skeletal anchorage at that time, but we just thought that we can make the surgery on the mandible for the extraction of all those deciduous teeth that was impacted, including the second premolars. And we expanded for bonding attachment on the canines, the first premolars, and the 2 first permanent molars. We have placed 2 fixed mini plates on both sides of the mandibular body to extend to occlusal support of the eruption of those teeth. So the orthodontic eruption was initiated with light night-eye wires, supported anteriorly by the incisor and posteriorly by the tubes bonded on the occlusal extremity of the fixed mini plates. So it was just this, the lower arch, and this was the situation at that time. So we made the surgery. This is his photos at that time, and then I have bonded. This was not the right tool, but I have used regular brackets. In the surgery, I supposed to use small eyelet would be better, but at that time, back in 2001, I have placed the mini plates and bonded these 3 teeth on both sides. You can see that I have bonded a tube on the extremity of the mini plates, and then I'm using the anterior incisors and the 2 mini plates to bring these teeth towards occlusal, and that's what we did. using the mini plates to erupt these teeth, and they begin to erupt very nicely. Now we can see that it's almost clearance of the teeth. You can see that the first premolars has a delaceration on the both roots, because it was touching the cortical base plate of the mandible, and now we can see that the first molars are erupting as well as the canines and the first premolars. So this was a situation at this time. You can see that the position of the bracket, it's not perfect because we bonded on the surgery, and at that time I can change the position of the bracket, and that's what we did. You just change the position of the brackets to bring the teeth into its proper inclination. You can see that the molars are erupting as well. And then we decided now to accomplish these results also in the upper jaw. So we did remove this Hyrax expander, remove the deciduous teeth. This was a fantastic result on the lower side. This right first molar did not erupt because thick gingiva at that time. So I almost, in some situations, I just remove part of the gingiva to facilitate the eruption. And then we made the surgery on the maxilla, removing all the deciduous teeth and also 2 premolars, and do the exposition for bonding attachments to the canines, 2 premolars and 2 molars. The surgery were performed under general anesthesia, and the surgical flaps were fully closed and sutured. The superior teeth were erupted by the inferior teeth and the mini plates with extrusive mechanics using vertical intermaxillary elastics. At the best time, their initial attachments are removed and the brackets of choice are placed at the ideal height and mid-labial position. So the elastic ligatures should be changed several times until the teeth erupt adequately. Then the rut, uprighting, rotating, and torquing auxiliaries may be applied to complete full alignment, and occlusion should be achieved at the end of treatment. At this moment, the patient is already 15 years old and still on treatment. So this, the duration of the treatment of this boy is almost 7 years, but he was very cooperative. So this is the left side and the right side. We bonded some attachments and begin to use extrusive forces to try to erupt all these teeth. So whenever the patient opens the bite, he's doing force to erupt these teeth. So it's very interesting mechanics, but we need to have the patient cooperation, because if the patient do not cooperate, using the elastic will not have the results, right? And this patient was very nice patient, and he wants to have his teeth, so he was using a lot these elastics. This is an interesting photo. You can see that just the elastics and no teeth. So now we can see more clearly the position of the teeth, and then we just try to erupt them very nicely. And it was a very difficult case. At this time, this patient had a cross bite on the canine, so I put a bracket, a tube, a button, sorry, on the palatal aspect of the canine, just to try to correct this cross bite that was created. And this was the result. Sometimes we can see that the gingiva is very thick, so I just try to remove parts of the gingiva to facilitate the tooth movement. And this was accomplished by using these vertical elastics. It was very difficult to treat the patient, but the result that we are having, it was very interesting. You can see the delaceration of the roots of the molars. But anyway, he was using a lot these elastics. At this point, I just made a hook on the mini plates, also to use the elastics, and we are getting to a nice occlusion now. This was the result that I was achieving. At this time, I had this canine on a class 2 position on this right side. So I just used some interproximal stripping on the incisors between the canines on the lower aspect, just to try to have more interesting occlusion on that side. So that's what we did. And we finished the case like this. Okay. Almost all these teeth was bringing for forced orthodontic eruption. This was a very challenging case, and back in 2004, I have finished the case. This is the final photos of the treatment. Okay. I think it was a very nice result for a boy that would not have any teeth, right? So at the end of the treatment, 15 years ago, and this is some back in 2005, a little bit opening of spaces on the right side, but the patient has a nice occlusion. And well, I have accompanied this patient until now. He has some periodontal issues, and at this time he was having some problem with this lateral incisor, and he had to put an implant on the lateral incisor on this side, in the first molar on the other side. But anyway, I think it's a very nice result until now. So this was the case. So conclusions: the need for early diagnosis and removal of all obstacles to the eruption of the permanent teeth, and the application of forces at the biologically appropriate time to bring the unerupted teeth into occlusion. So the patient's motivation and compliance are very important keys to achieve good results in patients suffering with failure of dental eruption. So let's just try to finish my presentation here. I want to thank all of you to staying until now. Just show the last case with ankylosed teeth. This was a picture that I had also with Professor Yuri Kudo, one of the main authors on the subject of impacted teeth and ankylosed teeth. This was a 4-year boy with an ankylosed second molar. We just tried to erupt these teeth by using the same type of mechanics. At that time, we didn't use a skeletal anchorage, but we can see that the molar is impacted and ankylosed. We just did a bonded annihilate attachment on the occlusal surface and do a lingual arch to stay as an anchor unit. So we just made a surgical luxation of this second molar and used these erupting elastics, and then the teeth just came into proper occlusion. So I wanted to just finish my presentation showing this case, because if we have maybe right time to do the right diagnostic, we can accomplish very nice results. So this is the initial, the end of the treatment with the eruption of an ankylosed second molar. Okay. So I would like to thank you all for your kind. I have almost 125 participants at this time. I want to thank you all for your patience with me, and I would like to open a panel of discussion, so we can open our mics and our cameras, and we can, if you like, we can answer some questions that you may have. Okay, Professor, thank you very much.
Okay, for a while. Thank you so much, Professor. It was really great, really great time to learn about your knowledge. We respect your passion for try to show us your great knowledge and great experiences. Yeah.
Thank you.
All right. And
Thank you.
and many. Okay. As you know, I'm oral and maxillofacial surgeon and specializing in orthodontic surgery. So I have some orthodontists of my friend who referred their jaw surgery patient to me. And they also refer the patient have impacted canine for extraction surgery or bottom bonding. That is kind of interesting surgery for me. Okay. However, you know, surgeon just to do surgery and couldn't see and know the progress after surgery. So today it was a really meaningful time to me to learn about that. Thanks, Professor.
Okay. Thank you.
And yeah, and you introduced some non-surgical cases at the beginning of your lecture. Yes. Make enough space for impacted canine to eruption by moving the root of lateralis to medial and move the root of premolar to distal.
Yeah.
Actually, the treatment was more unfamiliar to me since I've always seen patients need extraction or bottom bonding surgery for first eruption. So it was amazing to see the orthodontist treating them like that.
Yeah. But we have to have the right time to do it, right? Because the teeth have to be in the time for eruption.